Good evening and welcome everyone. My name is David Choi and I am a clinical pharmacist at the University of Chicago Medicine here in Chicago, Illinois. And on behalf of the American Liver Foundation and the Illinois Associate Medical Advisory Council, I would like to thank you for joining for the third and final program for the 2021 Associate Healthcare Management Series. The title of tonight's program is The Role of the Advanced Practice Provider in Diagnosing and Treating Hepatocellular Carcinoma. As a courtesy, I do want to mention that this program is being recorded and will be posted on ALS YouTube channel for future viewing for those who may not be able to join us this evening, or even for those who would like to review some of the information presented tonight. As a reminder, the mission of the American Liver Foundation is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. As a not-for-profit organization, ALF relies on the generosity of its stakeholders and hope that you might be able to make a donation so we can continue to fulfill our mission. All the presenters this evening are volunteering their time and expertise and will not be compensated financially. A donation link is in the chat box for your convenience. This slide represents the Illinois Associate Medical Advisory Council members. The purpose of our council is to meet quarterly and provide guidance to the ALF staff in terms of unique needs of the Illinois liver community here in Illinois. The program this evening, as well as additional lectures, are a result of these meetings. You may not be aware of the resources ALF has to offer, and I encourage everyone to visit the website. There you will find upcoming educational programming for healthcare professionals, patients, and events such as our upcoming 45th anniversary Legacy Gala on October 21st. You can also learn more about upcoming events and programs through ALF social media platforms. A link to ALS resource can be found in the chat box, so please bookmark it for future reference if you'd like. So just a few housekeeping items of using Zoom as our platform. It'd be wonderful if everyone would mute and turn off your cameras to eliminate any background noise and distractions during the presentation. As a reminder, this program will be recorded for later viewing. If you have a question, please include them in the chat or unmute yourself during the Q&A session to ask it live. The format for this evening will be our two presentations followed by the Q&A session. So please save your questions for the Q&A session at the end of both presentations. For your optimal viewing pleasure, please select Speaker's View in your menu. It is now my pleasure to thank and introduce our first speaker for this evening. Again, I am David Choi of the University of Chicago Medicine and will be your moderator for this wonderful evening. Our first presentation will be by Hazel Domingo. Hazel Domingo is a board-certified physician assistant at Northwestern Medicine Division of Hepatology. She completed her Master of Medical Science at Northwestern University and her Bachelor of Science in Nursing at Madonna University. She has worked in healthcare for 16 years, first as a quality assurance coordinator, then as a nurse 7 years, and finally as a PA for the past 6 years. She worked in solid organ transplant at University of Maryland prior to joining Northwestern Medicine in 2019. Hazel is passionate about patient safety, delivering compassionate care, and empowering patients to become active members of their care team. She strives to practice to the full extent of her scope and license. She also endeavors to promote PAs and NPs as integral members of the healthcare team and for the high quality care that they deliver. Hazel was a COVID-19 bride and married her husband, Andrew, at a courthouse during the pandemic. They love to travel, hike, and go on camper van trips around the world. She grew up in the Philippines and is fluent in Tagalog. All right, Hazel, I'll hand it off to you.
Thanks for the introduction, David. My name's Hazel. I am one of the physician assistants at Northwestern, and it's a privilege to present to you guys tonight. Tonight, I'd like to focus on the roles of PAs and NPs in the diagnosis and treatment of liver cancer. So as you know, liver cancer is the 6th most common cancer worldwide, 4th leading cause of cancer-related death globally. By 2025, it's predicted that there will be over 1 million individuals affected by liver cancer annually. Hepatocellular carcinoma is the most common form, and they comprise about 90% of cases. HCC incidence and mortality are increasing in the different parts of Europe and in the USA, and it's actually the fastest increasing cause of cancer-related death in the US since the early 2000s. And it's projected to become the third leading cause of cancer-related death by 2030 if these trends continue. So these are the strongest risk factors of HCC. Over 90% occur in patients with chronic liver disease, particularly cirrhosis. And the cirrhosis obviously is the strongest risk factor, with about an annual HCC incidence of 1 to 6% in that population. The next is hepatitis B virus, although it's more commonly seen in Asia, where they comprise 60% of cases, in Africa, where it's 20% of cases. And then Hep C is also Hep C cirrhosis particularly, but in the age of DAAs, it's substantially decreased, although now there is a rise of hepatitis C virus incidence in young people who inject drugs. NASH is the fastest growing etiology of HCC in the West, and it's about 15 to 20% of cases. And actually, they've found that 25 to 30% occur in the absence of cirrhosis. Alcohol, as we know, is also a huge risk factor, with 15 to 30% of HCC cases, depending on the location. Less prevalent, but also a significant risk factor, is hemochromatosis, with up to 45% of patients with hemochromatosis developing HCC in their lifespan, primarily biliary cholangitis and alpha-1 antitrypsin deficiency. So why do we do surveillance? It's because the prognosis of patients at diagnosis is driven by the tumor stage at the time they're diagnosed. Curative options can provide a 5-year survival exceeding 70% if you diagnose it early, at the early stage. The median survival is around 1 to 1.5 years for symptomatic advanced stage cases that are treated with systemic therapies. And therefore, we recommend HCC surveillance in high-risk individuals. And this all initially came from a study, a randomized controlled trial in China among over 17,000 patients with HBV infection, where they found that if they performed HCC surveillance, the HCC-related mortality decreased by 37% compared to those who were not screened. They tried to replicate this study, but obviously they couldn't, because once the patients knew about that, they didn't want to be randomized to a non-surveillance group. So many societies recommend HCC surveillance for patients with cirrhosis from any etiology, child A or B. It's not recommended for patients who are child C, who are not a transplant candidate because of their poor survival. And also non-cirrhotic hepatitis B patients, particularly Asian males who are 40 years and older, Asian females over 50 years, a Hep B carrier with a history of family history of HCC, and African Black people with hepatitis B, given the HCC incidence in that population starts at an earlier age. They've also found that performing surveillance every 6 months yields improved survival compared to annually or every 3 months. The AGA also now recommends to screen patients for HCC if they have NAFLD or non-alcoholic fatty liver disease, if they show non-invasive, if their non-invasive markers show advanced liver fibrosis or cirrhosis. And so this is a study from 2020 by Chen from University of Michigan, where they've, in a US cohort of 1,001 patients, they've found that each 10% increase in the patient's time under surveillance, so every time a patient is covered by HCC surveillance over a 6-month period, that was associated with decreased mortality. And so this also shows why we should be screening these patients. So we want to be preventing these people from dying. This is a study of patients with chronic hepatitis B. The results are actually pretty disappointing, as you can see. So they looked at patients, who are considered high risk, those people with cirrhosis and chronic hepatitis B that meet the criteria I showed you earlier. They also compared patients seen by GI or ID specialists versus non-GI or ID specialists, and then they compared patients with no cirrhosis, decompensated cirrhosis, and compensated cirrhosis. And across the board, only about 4% of patients were on time with their HCC surveillance. And this is despite knowing that surveillance saves people's lives. Interesting to note, though, is that patients who were seen by GI and or ID specialists have a higher surveillance rates compared to people who are not seen by specialists. This is another visual abstract, which just basically shows that in patients that they studied, 37% of patients who were diagnosed with HCC in the past 12 months didn't have regular outpatient care, and 32% didn't even know they had cirrhosis. And if you look at the bottom here, only 9% of those over 1,000 patients had consistent surveillance. And so there's been some care management initiatives and quality improvement initiatives, but these initiatives don't really address the main issue, which is lack of access to care. And on top of that, we already have low access to care to begin with, then we are hit with COVID. This is a graphic made by Dr. Tapper from U of M again, which, he said that the third wave effect of the COVID-19 pandemic would be, patients being lost to follow-up, misdiagnosis, incomplete cancer screening. And, I believe this doesn't just apply to patients with cirrhosis, but everyone across the board. This is a paper by Dr. Mahmood from the VA, where they looked at the 2020 data. The blue ones show the HCC surveillance rates from 2019, and then the orange shows from 2020, and you can see that it's significantly lower in 2020. And of course, we already knew that this just from looking at our patients and seeing what's happening in our clinical practice, but it's good to actually have objective data from an institution as big as the VA. So when we say lack of access, particularly in hepatology, what do we really mean? So there's some papers out there saying that in the US, there's only about one hepatologist for every 330,000 patients. And some say there's only about 1,000 or so hepatologists that serve the communities. In 2013, there were only 430 physicians who were certified in transplant hepatology. And in 2013, there were fewer than 2,000 AA SLD members that indicated that they practice in hepatology more than 50% of the time. And this is with the background of knowing that there's projected to be, almost 1 million patients with cirrhosis. Although to be fair, I didn't confirm if that's worldwide or just the US, but that's still a lot of patients. The other thing to think about is, where do hepatologists practice? So they don't, some of them practice in university health centers with transplant centers, some in non-university settings, but still do transplant, some in community practice. But if they are in teaching hospitals, they are not purely clinical most of the time. So they do inpatient rounds, they do clinical research, they teach, they have speaking engagements, they have administrative responsibilities, and they're active in national societies and associations. So this further limits their time to serve patients and see patients. In this paper by Dr. Russo, it's predicted that there will be a shortage in hepatologists in both adult and pediatric world. And this is even though they included advanced practice providers in their survey. So what are advanced practice providers? So advanced practice providers actually originated in the 1960s because there was a shortage of primary care physicians. So there are PAs, nurse midwives, nurse practitioners, nurse anesthetists. I'm sorry if I'm missing some other groups, but they were the product of a demand for greater healthcare access, especially the nation's underserved. And because of the shortage of physicians and specialists, APPs have played a big role in delivering healthcare, not just in, since the 1960s, but well into the 21st century. So let's start with PAs, because I'm a PA, happy PA week. But the first class of PAs were formed in 1965 by Dr. Eugene Stead from Duke University. And the first PAs were actually Navy hospital corpsmen, and they were trained medics during World War II. And doctors that knew about their training, fast-track training of doctors during World War II, so he kind of patterned that for the program. And this type of program was, federally accepted immediately and was backed as early as the 1970s as the creative solution to physician shortages. Currently, there are over 150,000 PAs across the US across medical specialties. NPs also started in the 1960s, started by Dr. Ford and Dr. Silver. And then the first early master program for NP started in 1967. And currently, there are over 270,000 NPs in the US. And both jobs are ranked number 1 and number 3 by the US News this year. But we always question the quality of the care that nurse practitioners and PAs provide. Well, since 1971, this has been studied, and the very first one was the Burlington randomized trial. It was published in the New England Journal of Medicine, which showed that the quality of care provided by nurse practitioners is comparable to those provided by physicians. And this was, I think, in the community practice. This is the study that evaluated the quality of HIV care provided by NPs and PAs as compared to physicians who are HIV experts and non-HIV expert physicians. And they've actually showed that NPs and PAs performed statistically significantly better than generalist non-HIV experts in 6 out of 8 quality measures. And these are the measures that they looked at. And on top of that, NPs and PAs also outperformed HIV expert, gen med, and ID physicians when it comes to performing pap smears and PPD testing. It's important to note, though, that in this study, 46% of the patients were also seen by MD, even though they were seeing an APP. And also, the APPs were HIV experts, and they've been working in the field for a long time. And usually, they practice in physician APP teams. The other thing that's brought up is, can APPs manage complex patients? And this study from Blue, they compared the care provided. This was from the UK, provided by the specialist nurse for patients with heart failure, and they found that when the specialist nurse intervened, the patients had less readmissions for worsening heart failure, and actually less death. And this is another one that shows that also from the UK, that when the UK mandated that all patients with Hep C have a clinical nurse specialist in their care, they found that clinical nurse specialists have increased linkage to care. More patients got liver biopsy, less patients were lost to follow-up, and more patients were treated for Hep C. And then this is just a paper showing that NPs can also perform outpatient paracentesis, which can help reduce ER visits. And then this paper by Dr. Tapper from University of Michigan just came out last year, was looking at the quality and outcomes of care provided by APPs for patients with cirrhosis. And this is a busy slide, but I want to point out that, patients seen by advanced practice providers, 41% of them have over 5 comorbidities. So these are very sick patients. And compared to those not seen by advanced practice providers, it's pretty similar, like the incidence of HE, ascites, and varices. So, APPs in hepatology do see sick patients. They found that patients who are seeing APPs have higher incidence of screening for HCC. And we've actually done a smaller study of a group of patients here at Northwestern, and it's the same for us. Patients seen by APPs have higher screening rates. And then this is the association of provider type with mortality as compared to, these variables. And you can see HCC increases the patient's risk of mortality, but if they're seeing an advanced practice provider, that's associated with lower mortality rates. Similar to, seeing hepatology or going to a transplant center. And then knowing all of that, are we just saying that, APPs can just rock the world and let's just forget about the hepatologists? No, because if you look at this, patients who are being seen by a team of both hepatologists and APP have overall, better outcomes, higher screening rates, better varices screening, and less 30-day readmissions. But I would say that APPs do cost more. But maybe we get what we pay for, just because, APPs are associated with higher screening rates. Maybe that accounts for that extra cost. They're seeing patients longer and they're seeing patients more frequently because the patients are sicker. So APPs can help not only in seeing patients, we can help with quality improvement projects, we can help facilitate the HCC conference, we can lead care management programs as long as we're trained in specialty care. Because as you know, we have less training. We graduate with a master's degree, sometimes a doctoral degree, but still less training than our hepatologists. So we do need that training in order to gain experience and expertise and manage complex patients such as those with cirrhosis. And I would also like to encourage our fellow APPs and even physicians to help publish more data on the quality of our care and our outcomes. Finally, going back to HCC, this is the Barcelona Clinic liver cancer staging system, where patients, obviously who are diagnosed early have a higher survival rate. And I just want to point out also that, choosing treatment should be done by a multidisciplinary team involving the surgeon, the hepatologist, the oncologist, radiation oncology, interventional radiology, palliative care, and others. So where do APPs belong here? So there are APPs in liver transplant and hepatobiliary surgery. There's some papers published about that. There's APPs in interventional radiology, in oncology, and also in palliative care.
All right, thank you for the wonderful presentation, Hazel. Now I would like to introduce Elena Ignatiev, who has been a nurse for over 20 years and has had the pleasure of working in a community setting as well as a tertiary care university setting. She has experience in many areas of nursing, including med-surg, ICU, PACU, administration, gastroenterology and hepatology, as well as her current focus in the outpatient oncology setting. She completed her Doctor of Nursing Practice DNP degree at the University of Illinois at Chicago. Elena has been at the University of Illinois at Chicago, and Elena has been at the University of Chicago for 13 years. And in her current position as a NP for the section of hematology and oncology, GI solid tumors for the last year and a half. She has also been a clinical assistant professor at the University of Illinois at Chicago College of Nursing since August of 2020, When time allows, she loves to travel, hike many of the forest preserves in Cook County and beyond, cook, and spend time with her family. Take away, Elena.
Well, thank you for that fabulous introduction, David. So thank you everybody for having me. We're going to get started here, hopefully picking up where Hazel had left off. And I am focusing more on the role of the advanced practice provider in the treatment of HCC. So typically, when a patient has been identified as having HCC, we need to evaluate this. And the American Liver Foundation, as well as the National Comprehensive Cancer Network, NCCN, both recommend actually having multidisciplinary liver tumor or HCC clinics that consist of a hepatologist, an oncologist, transplant surgeon, and interventional radiologist. The NCCN goes further to recommend also multidisciplinary conferences or tumor boards, which again would consist of hepatologists, oncologists, your transplant surgeons, the interventional radiologists, as well as the radiologists themselves, for case discussions and developing a plan of care for patients who have HCC in general. We have to move on, unfortunately, to systemic therapy for many patients when their tumors are out of criteria in many ways. If the lesion itself is unresectable due to its location or its size, or the patient has a very poor performance status and would not tolerate a very large procedure such as a resection, we tend to focus more on systemic therapy at that point in time. In addition, patients who have been deemed not to be a transplant candidate under UNOS criteria would now be funneled into systemic therapy. And lastly, if all of our options for local regional therapy have been exhausted or deemed not appropriate, maybe again due to the size or location of the tumor itself, we need to find an advisable option for the patient in terms of treatment. And that's where systemic therapy really comes into play. There's a lot of coordination of care that really goes into getting a patient on treatment with systemic therapy. Even though the focus now transitions more to oncology, and these teams typically consist of a physician, an advanced practice provider, a nurse, as well as infusion therapy nurses when it's appropriate, we also still have to keep our hepatology team and our interventional radiologists, as well as our nutrition and dietitian teams, social work, and palliative care involved. Typically, these patients have chronic underlying liver disease and come to us from hepatology, so they have a longstanding rapport with our hepatology team, and they do require maintenance and monitoring while on therapy. Oftentimes, these patients will be cirrhotic. Perhaps they need intermittent paracentesis if they've developed ascites. Do they need ongoing monitoring for esophageal varices? This is where that coordination comes into play with hepatology. Interventional radiology, on the other hand, may have been at the initial diagnosis when the patient came to the liver tumor clinic and found to be not a candidate for transplantation, resection, or local regional therapy at the time. Their expertise may have been tabled for a later point after undergoing systemic therapy and possibly intervening in the future, depending on the success of systemic therapy. So we always need to keep everybody in the loop. And of course, there cannot be any more important people than our dietitians and our nutrition experts with our patients with any chronic liver disease, and their focus on ensuring that they get our favorite thing: protein, protein, protein. Social work is another wonderful aspect of working in oncology. They are readily available to us and offer so much assistance to our patients, especially courtesy of the American Cancer Society. So a very valuable part of the team, and palliative care. And I will touch on palliative care and nutrition a little later. So the patient has been deemed appropriate for systemic therapy. We need to decide what our systemic therapy should be. We do have options now that are actually FDA approved. And when I first started in hepatology back in 2008, at that time, sorafenib was just becoming approved for both renal cell and HCC. So that was very new on the market, FDA approved at that time, and we've come quite a long way since that point. We now have actual infusion therapies that are FDA approved, and as you see here on the left, the atezolizumab and bevacizumab combination was recently approved in 2020 by the FDA for HCC in terms of first-line systemic therapies. There are a couple of caveats, however, to the use of atezolizumab and bevacizumab. They are both monoclonal antibodies, so not the traditional quote-unquote chemotherapy that patients may be anticipating to treat their cancer. With the bevacizumab, it has a high risk of bleeding. So with this patient population in particular, cirrhotic patients with thrombocytopenia, we need to make sure that we minimize that risk as much as possible before starting them on treatment. And that is why specifically under the FDA approval, patients are required to have an endoscopy within 6 months of initiating treatment. So if they do happen to have varices that we can ban, we need to do that before starting them on treatment. Also, this was unfortunately only approved for Child-Pugh A. So we do have some limitations as to what portion of the population would be appropriate to be treated with the infusion therapy here with the atezolizumab and bevacizumab. The one nice piece of this is that patients only need to have an infusion treatment every 3 weeks. So they come in, they're there for 2 hours at most, and they go home. So in terms of ease of administration, it's actually pretty simple. The patients don't have to do anything except for show up, and then they go home. In addition to the atezo and bev combination for second or third line therapies, for infusion, we have nivolumab, again, a monoclonal antibody, as well as FOLFOX. And FOLFOX is one of the main backbones of any GI cancer treatment. Again, these are second or third line treatments that are available. These are typically pursued if patients are ineligible for TKIs or tyrosine kinase inhibitors, which are the oral therapies. And the nice caveat here with the nivolumab is it can actually be safely and effectively used with Child-Pugh A or B patients. So we have a little more leeway with the nivolumab than we do with the atezolizumab and bevacizumab. So those are our infusion therapies that we have available to patients. Switching now to the oral therapies, again, sorafenib has been a mainstay in HCC treatment since 2008. And shortly thereafter, again, in the same drug class, again, tyrosine kinase inhibitors, came lenvatinib as well as cabozantinib. These are all, again, approved for Child-Pugh A patients. And there are a couple caveats to each medication. However, generally speaking, the oral therapies are fairly well tolerated by patients, and I'll get into the specifics in terms of side effect management, but we've gotten much better in managing the side effects of these medications, and patients tend to gravitate more to oral therapy because they don't have to come into the hospital. So there are caveats to each one, but again, determining the most appropriate modality for treatment, whether infusion or oral therapy, typically comes from that multidisciplinary approach to the patient's care. So once that has been determined, the patient usually comes to see our advanced practice provider. And this is where my role starts. Education is a substantial piece of what I do with my patients. At my initial visit with the patient, it's typically the most time consuming. Fortunately, I'm able to spend quite a bit of time with my patients and reassuring them and reinforcing our goals of care, whether it be a bridge to transplantation, whether it be a bridge to more interventional local regional therapy, just reinforcing those goals of care with the patient so they're well aware of where they might be going. There's no ambiguity involved. And a lot of concrete information is very reassuring to patients. And then we move on to medication-specific information. We provide them with a lot of information regarding the medication they're being prescribed, whether it be the infusions or the oral medications. We go through and review all the side effects with the patients. We provide them with written material, and we review on how to safely manage those side effects, whether it be, unfortunately, with additional medication or perhaps changing administration times slightly, mitigating any kind of side effects by taking medications with food, any kind of non-pharmacological interventions that can be done in terms of diet and wellness and exercise. Anything that can be helpful to the patient is always obviously promoted in a very safe and comfortable environment for the patient. We also want to provide them with multiple options or not options, but avenues for accessing information. So not only do we provide them with written information, we review everything orally, but there's a great website that was put together quite a few years ago called ChemoCare that's readily accessible to patients and providers as well, that also offers a great deal of information to patients, and they do reference it often. At subsequent visits that we have throughout the course of treatment, whether it be at their next infusion time or a month after starting an oral chemotherapy, I try and do things in person as much as possible, simply because a lot of our patients tend to be older in population and it's a little bit challenging for them to do telehealth type of visits. But of course, we are absolutely open to that option. But in person, it's always nice to kind of renew and reaffirm what we're doing. Review how the patient's doing, how they've been tolerating their treatment. If they have any questions, things come up from time to time and you're like, oh, well, I'm sorry, I forgot to mention that last time, or, oh, we talked about this. You know, just review kind of the information that's been provided to the patient to begin with. Keep encouraging them. Patients need as much encouragement as possible. Cancer treatment is hard. It's very hard. You have side effects you have to navigate. You have to navigate coming into the hospital, possibly for infusion, or adding a pill to your pill regimen that you never had before, telling people that you have cancer. Just keeping them positive and encouraging them throughout the process is very important. And then navigating all those side effects, whether it's through medication, whether it's through meditation, whether it's through exercise, nutrition, psychiatry, therapy. There's so many options to help patients navigate through their course of treatment, and we're there to help coordinate that for them. And definitely empowering our patients and making them be an active participant in their healthcare has helped dramatically. I always like to give patients options. You know, we can do this. We can do this. Either is effective. What would you prefer to try? So we can try option one for a period of time. And if that doesn't work, we can move on to option two. So getting them to be much more participatory in their care and empowering them to do so is very beneficial for their own peace of mind, as well as, you know, their adherence to therapy. And of course, my favorite mantra is write it down. We have all these fancy schmancy ways to communicate information, and the after visit summary, as we see here, is one useful way to do that. I often put paper to pen and pen to paper, I should say, and just write things down as I'm saying things to patients, which they can follow along with and find much more efficacious. Just providing it to patients on a piece of paper that they can take home and they can keep handy is always a good option. Telehealth, as I mentioned, is always a good way to follow up with patients. We do this a lot with our oral therapy patients. The goal is really to be accessible. There are a lot of questions that come up. Again, a lot of anxiety around the diagnosis and treatment. And it's also a great way to engage family members. They may not be able to travel in, but they'll be more accessible if I can pop on a video visit with my provider on my lunch break with my dad who's getting treated for his liver cancer. So you can engage a lot more family members that way as well. So again, reinforcing a lot of education with our patients. Moving on to side effects, another large piece of the puzzle for me. Focusing more on the monoclonal antibody treatments that we have available. Again, this is the atezolizumab and the bevacizumab, or atezo-bev for short, as we like to call it. With monoclonal antibodies, we tend to have a general adverse reaction or side effect of the itises. And this is because of the nature of the treatment. This is immunotherapy. It can produce an inflammatory response in multiple body systems. So we always keep an eye out for your pneumonitis, your arthritis, your thyroiditis, your colitis, unfortunately. So typically when patients present with unmanaged diarrhea that have been taking Imodium routinely around the clock and they're still having diarrhea, we start to focus more on a colitis type of a situation, which would require a steroid taper. Fatigue is a typical underlying side effect for any and every chemotherapeutic agent I have ever encountered. So that is general across the board for everyone. With the monoclonal antibodies, we do see some nausea and vomiting, but it's really diminished in comparison to our standard FOLFOX type of a regimen or standard chemotherapy. Again, these are monoclonal antibodies, so immunotherapy. And the nausea and vomiting, although it can occur, is typically less prevalent in these patients. The proteinuria and GI bleeding are specific to bevacizumab. And the proteinuria can actually be mitigated by the addition of like a calcium channel blocker, and hopefully that can help. But oftentimes we have been forced to hold the bevacizumab during the course of treatment, strictly because of the proteinuria. And the GI bleeding, of course, why we do the upper endoscopy beforehand. You can develop mucositis with the monoclonal antibodies, which is easily rectified with a magic mouthwash or a dose reduction. And diarrhea and constipation, more so the diarrhea because it typically manifests itself as a colitis. Constipation can occur, but again, diarrhea is more prevalent. Conversely, with our oral therapies or our TKIs, the sorafenib, the lenvatinib, and the cabozantinib that we have, nausea and vomiting are by far the most common complaint from my patients. It's an oral medication. We always educate our patients to take them with food. It can be very upsetting to an empty stomach, so definitely after meals. Diarrhea, of course, in conjunction with that can be problematic. Managing that with Imodium is our standard protocol there. Fatigue, as I mentioned, is very, very typical with any cancer treatment. Rest, hydration, and actually exercise and activity can be very helpful to mitigate any fatigue. Hand-foot syndrome is a big one that we see, specifically more so with sorafenib. I don't see it as much with lenvatinib or cabozantinib, but this is a typical reason for stopping treatment for a period of time or dose reduction. And it's typically mitigated with applying urea, high concentrations of urea cream, like udder cream. I usually recommend my patients to start that right away. And just get in the habit of applying it twice a day to their hands and their feet to hopefully offset that from developing. Hypertension is another common problem. Again, with calcium channel blockers, they tend to be very effective in managing the hypertension with the TKIs. And neutropenia, as with any chemotherapy that we can see, the TKIs do cause a bit of a dip in the white blood cells as well as the absolute neutrophil count. So we do have to interrupt therapy on occasion for that as well. And then that can be also combined with some stomatitis, again, very similar to the mucositis we see with the monoclonal antibody treatment, but easily rectified with a dose interruption or some magic mouthwash. I just wanted to touch very briefly on oncologic emergencies that we need to be aware of, especially with our older patient populations. The most common 5 are listed here on the left-hand side of the slide. With this patient population and the treatment modalities that we use, the top 2 are typically neutropenic fever as well as cord compression. Anybody who has a fever and is on systemic chemotherapy, we are always worried about a neutropenic fever. So we are constantly monitoring their CBCs, as well as possibly augmenting treatment in terms of dose interruption, and if possible, growth factor administration. Cord compression, anybody who complains of back pain or lower back pain should be evaluated for possible cord compression and get an MRI within a day or 2 at most. Specifically, if they should do the whole cord compression MRI. And if you're worried more specifically regarding the lumbar region, you can start there, but eventually obtaining the entire spinal cord compression MRI. And this is typically with the HCC patient population due to metastatic disease to the spinal cord and spinal column. Palliative care is one of the most valuable assets that I have come to appreciate in terms of oncology care. The American Society of Clinical Oncology, or ASCO, actually put out guidelines in terms of palliative care and its involvement with patients undergoing cancer, specifically advanced cancer. So their recommendation, of course, is to involve palliative care very, very early on in the course of the patient's disease process and to be concurrent with treatment. It's a very integral part of treatment. Palliative care offers a lot of support to patients. As you can see with the visual aid here on the right, coping skills, comforting, spiritual support, pain management, referring to therapists or psychiatrists, pardon me. Really getting them involved early on in treatment is so helpful to patients. It allows the palliative care team to really establish a rapport with the patient, allows them to help with coping. This is a big change for a lot of people. Cancer is always a scary thing to hear from people, and palliative care is excellent in helping patients navigate that diagnosis, the anxiety surrounding it, as well as the subsequent treatment that's required. They can also assist with medical decision-making, and as I mentioned as well, pain management. So palliative care is a real integral part of what we do. I think the biggest hurdle with patients is when they hear palliative care, they immediately associate that with hospice and end of life, which is not the case. So again, getting palliative care involved early on can help dispel a lot of those misconceptions and offer a lot of support throughout the course of treatment. My favorite thing to talk about, food. Protein, protein, protein. My patients think I'm nuts. All I talk about is protein and food. Because as we mostly know, most of our patients with HCC do have cirrhosis and do have some nutrition deficiencies to begin with. Our protein count is just abysmal at times. And our recommended intake for patients with cancer, generally speaking, with liver cancer is more, but generally patients with cancer, recommended daily intake of protein is between 1.2 and 1.5 grams per kilo per day. So for your average 80 kilo patient, that's a lot of protein. That's really hard to do. So encouraging patients who have early satiety to ingest sufficient amounts of protein can be a challenge. We can do protein shakes. My favorite personal accompaniment to protein is peanut butter and eggs, not together, so that would be unfortunate. But eggs in 50 different ways. You can eat peanut butter out of a jar with a spoon. Just helping patients navigate their nutritional needs is a big challenge as well, because that, of course, ties in with their energy level, their level of fatigue, and ultimately their performance status. So we often involve our dietitian with our patients on that first visit, just to establish a rapport with the patient. And then as they move through therapy, If their nutritional needs increase, getting the dietitian even more involved and possibly getting supplements if they're unable to tolerate more solid food. So we need to kind of work all those nuances and navigate all of that for our patients. But the dietitian and nutritionists that we have are an integral part of that multidisciplinary team. So while we're helping our patients navigate through treatment, we have to see how they're doing. We need to restage after certain periods of time, whether it be 3 months, whether it be 2 months, depending on what our goals of therapy are. Our preferred modalities, according to NCCN, for liver cancer patients in particular, would be a CT of the chest, always evaluating for metastatic disease or progression of metastatic disease in the chest, and a CT or MRI of the abdomen and pelvis, of course, with and without contrast. There is limited utility in the use of a PET scan with HCC patients, unless we're looking at specific lesions. But most of the time, the CT or the MRI is sufficient in terms of restaging and to see how the patient has responded to therapy. This really helps dictate our future therapies. If we have progressed on treatment, what is our second line or possibly third line treatment option? Are we going to switch to an oral from an infusion, etc.? If the patient's responding very well, do we continue? Do we augment therapy because the patient's performance status or their quality of life has declined as a result of side effects or poorly managed side effects in terms of the patient being unable to really adequately manage them while at home? So there's a lot of caveats to furthering therapy, and of course, getting that multidisciplinary team involved again, having those radiology or tumor board conferences and getting everyone's input as to where the future for that patient leads. So that pretty much sums up the role of the advanced practice provider in the management of hepatocellular carcinoma. Thank you everybody for your time. And please let us know if you have any questions.
Thank you so much, Elena, for that great presentation. I wanted to invite Hazel to come back and turn on her screen and unmute the microphone. While Hazel is doing that, I think we received a question for you, Elena, from Melanie. With the question being, how often are EGDs required for those on monoclonal antibodies?
Well, thank you, Mel. That's a great question. So as I mentioned previously, they need to have undergone an upper endoscopy within 6 months of initiating treatment. However, after that point, we really defer that management to the hepatologist. So for example, if the patient is going to be started on atezolizumab and bevacizumab, they have their baseline upper endoscopy, there's no evidence of any varices, we wouldn't need to continue that from an oncology perspective in terms of their risk of bleeding. We would defer that to hepatology in terms of when they felt it appropriate to rescreen the patient if it was necessary.
All right, thank you. And then Sarah put in a couple questions. So one, how long have you seen a patient continue on sorafenib? Most data I've seen demonstrates elongated life by 13 months, but if they live longer than that and tolerate it, they're hard to stop. So that's the first question.
So I have a couple of little caveats to that question, Sarah, as a matter of fact. From my days in hepatology, I actually had a patient on sorafenib for 5 years. So this was very early on after approval. He did very, very well, very limited side effects. At that point, there wasn't seen to be any utility in stopping because he was tolerating treatment and he actually had stable disease. He had multifocal HCC at that point and he was doing well. So there was no need to stop at that point. Typically, we do see, like you said, about 12 to 13 months in terms of what we like to term progression-free survival. So it typically depends on how the patient's restaging scans go. If we see progression, we're obviously going to discontinue that therapy, in particular sorafenib. But in terms of tolerance, my max on the oncology side has been just about 2 years. So we see more often than not, we'll see progression with the sorafenib in particular.
All right, and then part two of that question, do you see cord compression more in IV infusion, oral therapy, or equal?
It's pretty equal. It has more to do with metastatic disease. So if the patients come to us and they already have extrahepatic multifocal HCC, and we're just giving them an option in terms of some sort of systemic palliative type of therapy, we'll often see those patients develop cord compression quite frequently. But if they don't have any extrahepatic disease and really multifocal HCC within the liver itself, it tends to be less frequently. But in terms of hematologic emergencies with the patients that we have, simply because of the location of the liver itself, it tends to metastasize obviously to our bone and to the lungs most frequently. So that's where we see most of our hematologic type emergencies.
And then we have one more question from Michelle for both Hazel and Elena. How frequently do you restage HCC patients?
No, it depends on your goal of treatment as well as your treatment modality. So typically we'll restage after 3 months with oral therapies or sooner, depending on how the patient's presenting in terms of symptoms. Like if they suddenly start developing severe right upper quadrant abdominal pain that's radiating to the back, we're going to rescan that patient a lot sooner than the apportioned 3-month time frame. But typically with infusion therapy, we do every 3 months, unless we're trying to consolidate therapy or bridge them to transplant. We may scan them sooner, but that's where the input of that multidisciplinary team really comes into play.
I was just going to say, we also do every 3 months. I don't really manage patients diagnosed with HCC that are having chemo, or they go to oncology, but if they underwent Y90, we do every 3 months.
All right, so I just want to share that the virtual ALF patient-oriented conference will be next week from October 15th through the 16th. The link for that is in the chat section if that's something you want to take a look at www.alfevents.org/liver cancer conference. Just for the sake of time, I am going to finish up. All right. So, once again, thank you for everyone for joining our presentation today. And thank you for our speakers, and a special shout out to the Illinois Associate Medical Advisory Council, led by our co-chairs, Michelle Martin and Sarah Repking, for their leadership to bring this important information to you. As a reminder, these are the list of ALF resources, and we encourage you to take advantage of the information they offer to healthcare professionals and the patients. And of course, if you do want to make a donation, the link is in the chat box again, along with the link to ALS website. This does conclude the role of the APP in diagnosing and treating HCC, and we hope to see you in 2022 for our next program series. All right, thank you, everyone.